They own you. Why Wall Street just bought your DNA. The email said my rate, updated due to new risk. No accident. No late bills. Then a friend texts, "Did you do one of those DNA kits?" I did years ago. Meanwhile, Blackstone bought Ancestry.com in 2020 for $4.7 billion, about $261 per profile if you do the deal math. 50 million genetic files under one financial roof. Now imagine a shadow health score, like Equifax for your body, pricing your premiums, your job offers, even your loan. You never saw it, you never approved it, but it's there. $1 million question. Who owns that score on you? And how fast can you take it back? The birth of biological assets. To see how we got here, we have to rewind, but not far. In the 1990s, most medical info sat in paper folders. You were a stack of charts and a nurse's memory. Then came digitization in the 2000s and 2010s, electronic health records, patient portals, claims clearinghouses. The promise was simple: better care, fewer errors. The side effect was massive. Your life got turned into rows in a database. Here's where it splits. HIPAA sounds like a blanket, right? It isn't. HIPAA mainly covers doctors, hospitals, and health plans. The second your data flows to an app, a wearable, a data broker, or even your employer's contractor, you can slide outside that shield. And there's that magic phrase, de-identified. Take off your name, your address, maybe your birthday, and call it anonymous. But when brokers can stitch de-identified medical data to credit files, shopping records, and social media, re-identification isn't a stretch. That's the seam. So who can't use your genes against you? GINA, the Genetic Information Non-Discrimination Act, protects you in health insurance and employment. That matters. Health insurers can't set premiums based on your BRCA or APO status. Your boss can't demand a genetic test to hire you. But GINA has big holes. It doesn't cover life insurance, disability insurance, or long-term care insurance. That's not a rumor, that's the law. The AMA flags it. Genetic groups flag it. Even more, once a condition is manifest, you actually have the disease, GINA steps back and the ACA or ADA do the heavy lifting. People think they're fully covered. They aren't. Meanwhile, private equity saw a system flooding with data. Labs scaled up. Revenue cycle firms learned every billing code. EHR vendors owned the workflow. Pharmacy benefit managers captured prescriptions, refills, prior auth notes. Telehealth boomed. COVID pushed everything faster. Millions of tests, metadata everywhere. Capital loves repeatable patterns, and healthcare throws off repeatable patterns. So many followed the pipes. Then 2020 drops a loud signal. Blackstone buys Ancestry.com for $4.7 billion. Not a startup bet, a scale bet. Roughly 50 million profiles, plus the family trees that help link people even when the DNA is partial. Media pegs the rough per-person math at about $261. Is that a neat, perfect price tag for your genome? No, the company also sells subscriptions and genealogy services. But that back-of-the-envelope number tells you how Wall Street thinks. Per unit value, volume, and options to monetize later. Here's the leap. When financial players sit on big data pools, they don't think records. They think assets. Assets that throw off cash flows. License the de-identified cohort to pharma. Sell insights to analytics vendors. Create benchmarks for risk. Now remember how credit data became its own industry in the 1990s and 2000s. Equifax, Experian, TransUnion, then FICO scores and custom risk models. Opaque inputs. Denials by algorithm. Appeals that feel like yelling into a void. Health data is marching down the same road. So, what exactly becomes an asset? Claims histories. Prescription fills. Lab values over time. Wearable heart rates and sleep. Location-based social determinants. And yes, in some stacks, genetic risk markers or family history. Stitch those together, and you can build a predictive file per person. Likelihood of high-cost events, medication adherence, job stability proxies, even future expense curves. That's your shadow health score. It's not one number yet, not like a published FICO, but it functions the same way, an internal score used to price you. You might say, but my insurer can't use my genetics. True, for health insurance, GINA draws a line. But life insurers, disability insurers, and long-term care insurers in many states can ask about or use genetic info or its proxies. And employers? GINA blocks direct genetic discrimination, but plenty of data sits just outside that definition. Wellness programs device data, risk flags that are not genetic, but correlate with it. This is where the creep happens. The kicker is consent. Most of us click through app screens. We joined wellness plans to save $600 a year. We synced Wearables because the premium dropped. The permission was voluntary. But let's be honest, when your take-home pay is tight, that discount isn't a perk, it's pressure. That's how the marketplace collects clean, linked, ongoing data straight from you. The human cost shows up quietly. A job offer that never materializes. A mortgage rate a quarter point higher. A life policy that's not a fit at this time. No one says shadow health score. They say underwriting criteria. They say holistic risk. It feels personal, but it's structural. So why does Wall Street want this? Because risk sorting prints money. If you can predict future claims one notch better than the next guy, you skim margin everywhere. Insurance, lending, staffing. And because the data moats are deep, it's hard to switch away from your medical history. You can cancel a card. You can't cancel your pancreas. This is the birth of biological assets. Not because your body changed, but because the market did. Your data became durable, linkable, and priced. And once it's priced, it's traded. We're still early, but the scaffolding is up. The score is coming into focus. And unless we push back, it won't just price your premiums. It'll price your life. Inciting incident, the great health data land grab. 3 things hit at once. First, the swabs. In the early 2020s, COVID testing turned every strip mall into a lab line. Millions of samples, barcodes, timestamps, insurance IDs, symptom checklists, clean, labeled data flowing every day. Labs scaled overnight. Pop-up collection sites fed national processors. Turnaround time was money, and money poured in. What nobody talked about was the metadata. Not just a result, but where you tested, how often, which doctor ordered it, how fast you returned, what else your insurance covered that month. It built a time-lapse of your health life in real time. Second, the buyers. Private equity went on a roll-up spree. They bought regional labs, then the billing firms that touch every claim, then telehealth networks that sit between you and the clinic. Bundled together, they controlled the on-ramps and the checkout line. When you own the intake, the test, and the bill, you don't just see revenue, you see risk patterns. And with leverage, those patterns turn into assets. A lab contract is cash flow. A data feed is a side hustle. A nationwide footprint becomes a moat. Third, the DNA vaults. Direct-to-consumer kits had been stacking samples since the 2010s. By 2020, tens of millions of people had spit in tubes for Ancestry and trait reports. Then came the loudest signal. Blackstone agreed to acquire Ancestry.com in 2020 for $4.7 billion. 50 million profiles under one financial roof. Media did the quick math. About $261 per person if you pretend the database is the whole business. It's not, but the number stuck because it felt like a price tag on a human. And it told Wall Street there's a liquid market for genome-scale assets. While that was happening in boardrooms, insurers and pharmacy benefit managers were cutting data partnerships with analytics vendors. The sales pitch sounded harmless. Population health, fraud detection, better adherence. Under the hood, it looked a lot like a credit bureau build. Claims in, RX fills in, prior authorization notes in, social data layered on, scores out. Not one public number, but thousands of private ones. Propensity to churn, risk of lapse, likelihood of a $100,000 year. And because GINA blocks genetic discrimination in health insurance and employment, but not in life, disability, or long-term care, the heat shifted to those markets. Actuaries started asking new questions. Do you exercise? Do you share wearable data? Any family history? Have you ever tested? You could feel the outline of the shadow health score without anyone saying it. Get this, most of the sharing rode inside tiny clauses. De-identified research use. Improving services. Affiliates and service providers. You clicked continue because lunch break was ending. De-identified sounds safe, but when datasets are big and linkable, anonymity is brittle. Stitch a claims file to a prescription history to a location pattern, and the mask slips. Courts and regulators know re-identification is possible. Brokers know it's profitable. Microclimax. The fine print is the business model. Meanwhile, COVID gave cover for permanent changes. Emergency waivers let telehealth explode. Employers leaned hard on wellness, pitching premium discounts for connected devices. Health systems raced to cloud vendors to host portals, images, and models. Big tech offered storage, compute, and AI toolkits. If you're selling shovels in a gold rush, you don't need to own the mine. You just need every miner to pick your shovel. Here's where the land grab turns financial. Once the pipes exist, you can securitize the flow. Labs sign multi-year contracts with minimum volumes, priced per test, with data licensing on the side. Analytics firms license back insights to the same insurers that furnish the data. Pharmacies sell de-identified fill patterns to marketers and modelers. Each stream can be valued, discounted, and packaged. That's what private equity understands. Recurring, predictable, hard-to-switch cash. It's the same logic that made FICO a quiet tax on borrowing in the 1990s and 2000s. Build once, charge forever, stay invisible. And the public never sees the score. You see the outcome. The premium change due to updated risk. The bank nudging you to a higher rate tier because your profile doesn't align. The long-term care quote that doubles after a holistic review. People call customer service and hit a wall of scripts. The model isn't public. The feature list is proprietary. Appeals feel like superstition. Change one behavior. Hope it moves a number you can't see. One detail would prove crucial later. The same companies building these scores also sell compliance and fairness audits to themselves. It's like a credit bureau grading its own homework. Regulators are behind. Consumers are in the dark. And Wall Street is already counting the cash flows. By the end of 2021, the map was drawn. Microclimax. The pipes are in, the players are set, and the score is humming behind glass. Labs, claims, pharmacies, portals, clouds, and DDC DNA, consolidated, connected, and capitalized. The land was spoken for. The price signals were set. And the shadow health score had a home. The pipes, who controls the health data infrastructure. To follow the money, follow the pipes. Not the shiny apps. The back-end rails. The places your data has to pass to get care, fill meds, or get paid. That's where power sits. Start with electronic health records. A handful of vendors run most charts in the United States. Your portal, your messages, your meds list, those live inside their ecosystems. Hospitals weld workflows to these systems because ripping them out is like heart surgery. So EHRs become choke points. They decide which APIs exist, which apps can plug in, and how easy it is to move your record. Interoperability sounds great in brochures. In practice, the gatekeepers set the tolls. Now the master ledger, claims. Every diagnosis code, CPT code, NPI dollar amount. Claims clearinghouses sit in the middle like air traffic control. They route, scrub, and normalize the data so payers can pay. That single act, standardizing, turns messy life into neat rows. Those rows feed risk engines. They also feed data brokers through de-identified slices. Remember, covered entities under HIPAA are limited, but vendors and business associates sit close enough to touch the stream. That's the theme Wall Street loves. Pharmacy is its own empire. Pharmacy benefit managers negotiate formularies, rebates, and prior auth rules. They also see every fill, every switch, every lapse. Specialty pharmacies layer in courier tracking, nurse notes, and financial aid docs. Prior authorization dossiers are gold mines. Diagnosis, staging, failed therapies, clinician narratives. Put that together, and you've got adherence timelines and disease trajectories at scale. A PBM doesn't just move pills. It manufactures risk signals, then sells insights about them. Labs are where biology meets billing. Lab information systems tie barcodes to results and to ordering doctors. Over years, that becomes longitudinal phenotype. A 1C drift, lipid trends, tumor markers rising, viral loads suppressed. Link that to biobanks, and you can map genotype to phenotype. Direct consumer DNA repositories, like the roughly 50 million profiles Blackstone gained control over with the 2020 Ancestry.com deal, sit outside hospitals altogether. Private, capitalized, and connected through partnerships. Even when they promise de-identification, the value comes from linkages, traits, relatives, geography, family trees. That's a privately owned scaffold for future targeting. Then wearables and apps. Steps, heart rate, sleep, arrhythmia flags, food logs. Alone, that's lifestyle wallpaper. Paired with claims and fills, it becomes behavioral compliance. Did you walk after the statin started? Did your sleep tank before the ER visit? APIs fling this data into clouds where health systems already rent compute. Big tech runs the storage, the security, the machine learning kits. Owning the compute means owning the gravity. Once petabytes park on a platform, they rarely move. That's how platforms become quiet landlords of health data. Overlay social and financial data. Data brokers bundle addresses, income bands, household size, eviction risk, even catalog return habits. Researchers and regulators call it social determinants of health. Brokers call it segmentation. When you merge these files with medical exhaust, you can guess food insecurity, job volatility, and move risk. None of that is genetic, but it shadows it. Family history, zip code, and utilization together can predict conditions genetics might flag. That's how the shadow health score fills in, even where GINA blocks direct use of genetic info in health insurance and employment. Who coordinates all these pipes? A web of clearinghouses, switch vendors, EHR marketplaces, PBMs, cloud hyperscalers, and analytics shops. Contracts knit them. Business associate agreements legitimize flows. Research and quality improvement carve-outs widen them. And when one company owns multiple links, payer plus PBM plus provider plus analytics, the loop closes. Data gathered in care sets premiums. Premiums nudge care paths. Care paths produce more data. Vertical integration turns pipes into a flywheel. Here's the kicker: auditability is thin. You can pull a medical record. You can't pull a full routing map. You won't see each extract sent to an affiliate for service improvement. You won't see which de-identified bundle was licensed to which vendor. In credit, at least, there's FCRA and adverse action notices. In health data, notices come as policy updates and portal banners. The score hums behind glass. Meanwhile, incentives stack. EHR vendors earn on modules and marketplaces. Clearinghouses earn on each transaction. PBMs earn on spread pricing and rebates. Labs earn on volume and real-world evidence licenses. Clouds earn on storage and compute. Analytics firms earn on risk adjustment and member engagement. Every party benefits when more flows more often for longer. Friction costs money. Privacy breaks the loop. So the system is designed to keep taps open. This is why the pipes matter. Whoever runs the junctions can shape the shadow health score without ever naming it. They don't need a single master database. They need easy joins, durable identifiers, and terms that permit improvement. Add the 2020 Ancestry.com consolidation to that landscape, and you've got genotype next to phenotype, next to spend, next to behavior, ready to price your tomorrow. Microclimax, the quiet landlords already set your rent. The score, building the shadow health score. So what is this thing, really? Picture a silent profile that updates itself every day. Not one number yet, but a stack of signals that behave like a score. It sits behind logins you never see and changes how companies treat you. Start with the raw inputs. Claims data lays the base layer. Diagnoses, procedures, spend by month, gaps in care. Pharmacy files drop in next. Drug names, doses, refill timing, switches after denials. Labs add trend lines. A1C inching up, LDL creeping down, kidney function drifting. Wearables and apps feed daily cadence, steps, sleep, heart rate spikes, arrhythmia flags. Then there's the sensitive stuff, family history, and in some stacks, DNA risk markers or trait inferences from consumer tests. Remember, health insurers and employers can't use genetic information under GINA, but life, disability, and long-term care underwriters often can. That's the path of least resistance. On top of the inputs, vendors engineer features. They don't say diabetes risk. They say future cost probability at 12 months. They don't say genetic variant. They say early onset risk proxy from family structure plus onset age markers. Adherence becomes medication possession ratio. Activity becomes exercise consistency index. Missed appointments turn into care engagement score. They stack hundreds, sometimes thousands, of these features and let machine learning find patterns that predict expensive years. Then they do the part Wall Street loves: rank and bucket. High-cost risk deciles. Rising risk cohorts. Lapse likelihood. Impactable members who will save the plan money if nudged. Each tag unlocks a workflow. Outreach call, step-up prior auth, rate tier, care management, or simply watch. You never get the label, but the label gets you. Here's where the Equifax/FICO playbook shows up. Credit scores predicted default and priced loans. This shadow health profile predicts spend and prices everything around your health life. The models are proprietary. The inputs are furnished by a web of data suppliers. The outputs get sold back to decision makers. And if the model gets you wrong, the burden to fix it is on you. Except you can't see it, so you can't fix it. There's no Fair Credit Reporting Act for this world. But wait, you might say, genetics can't drive my health premium. True for health insurance and employment under GINA. Not true for life, disability, and long-term care in many states. Those markets can ask for tests or use family history. Even when they don't touch raw DNA, they can use proxies, early screenings, preventive surgeries, patterns that point to risk. That's how genetic signals leak into pricing without breaking the letter of the law. And about the math everyone quoted after 2020, roughly $261 per person based on Blackstone's $4.7 billion Ancestry.com deal. Is that the exact price of your genome? No, it's a crude marker. But crude markers matter. They tell model builders that personal biology has a cash value at scale, especially when linked to longitudinal records. If your data can spin off licenses to pharma today and underwriting signals tomorrow, it becomes an asset with a forecastable yield. Now the business model. Vendors pitch population health and fraud prevention. Both may be real, but the same pipeline feeds underwriting and pricing decisions. The output might be a percentage or a rank or just a flag. It rarely says deny. It says route to tier C, which means slower approvals, fewer choices, higher friction. In lending, that friction is a higher rate. In employment, it's a not a fit email. In insurance, it's a surcharge you can't quite decode. Does any of this help care? Sometimes. Predicting kidney failure can save lives. Catching med lapses prevents strokes. The issue isn't prediction. It's ownership and use. Who owns the derived features you generated by living? Who audits the model when it downgrades a zip code that happens to be mostly black or mostly poor? Who explains the decision when a Wearables missed syncs label you non-compliant? There's another layer, behavioral feedback. Scores don't just measure, they shape. If the system sees you as costly, it pushes hurdles. Hurdles cause delays. Delays cause worse outcomes. Worse outcomes confirm the score. In credit, that loop is well known. In health, it's faster and more personal because your body can't sit on the sidelines until the next cycle. So how do you spot the shadow score in the wild? Watch for vague phrasing tied to risk. We updated your tier based on multiple factors. Your offer reflects a holistic assessment. Your case didn't meet criteria. Those are score fingerprints. If there's no clear appeal path and no specific reason, you're probably staring at a black box. Microclimax. Once you notice the fingerprints, you can start fighting the ghost. And the escape? You won't outrun it alone. You can blunt inputs, sure. Opt out where you can decouple devices, kill shady app permissions, request deletion from DNA firms that allow it. Treat it like credit hygiene. But the real fix needs guardrails. Extend GINA to the lines it missed. Bring FCRA-style rights to health-derived scores and force audit logs so you can see when your data moves. Microclimax. Personal hacks by time. Policy changes by freedom. Case studies. When data becomes destiny. Meet Kim. Mid-40s, project manager, 2 kids, solid at her job. Her employer rolls out a wellness savings plan. Save $900 a year if you hit targets. Steps, BMI, blood pressure, cholesterol, non-smoker, and optional device sync. She signs up because, let's be honest, $900 is groceries. Month 3, stress hits. Sleep tanks, steps drop, BP creeps up. HR emails. You're moving to Tier B, surcharge pending unless metrics improve. No mention of genetics, GINA blocks that just engagement gaps. She starts walking at 10 p.m. to hit the step goal. Her manager notices late mornings. Performance review dips. The discount she joined for becomes a leash she drags. Across town, Marcus applies for a mortgage. Good income, clean credit, no missed payments. The banks offer slides across the screen. Approved, but rates a quarter point higher than he expected. The rep shrugs. Our model looks at many factors. What factors? He has no clue. Here's what he doesn't see. A third-party risk of instability. Overlay that blends job sector churn, neighborhood-level hospital utilization, and de-identified claims tied via address history. No raw health data with his name, just a shadow of it. It doesn't say deny. It says price up. That quarter point adds thousands over the life of the loan. Then there's Priya, 38. whose mom had early onset cancer. Priya did a consumer DNA test in the late 2010s out of curiosity. Years later, she applies for long-term care insurance. GINA doesn't cover this line, and in her state, the carrier can consider predictive risk. The form asks family history, early screenings, preventive procedures. She answers honestly. The quote comes back double. The letter says holistic assessment. She calls, asks about genetics. They never asked for her raw DNA, but the pattern screams risk. No law broken, just a market using the gaps. Now meet Dan, warehouse supervisor. His employer launches a Get Rewarded for Movement program with a $600 premium discount. He wears the tracker, then stops sinking. He's exhausted from night shifts, his kid's sick, he misses the weekly survey. The system flips him to non-compliant. Premium rises. He appeals, explains the family mess. The portal gives him a chatbot. To restore your discount, complete 4 consecutive weeks of engagement. He can't get a person to look at his actual life. The score moves, his budget tightens. Sophia's story shows the denial loop. She switches insurers. A specialist orders a brand-name med that kept her stable. Prior authorization triggers. The model flags a cheaper alternative. Pharmacy tries the switch. Side effects blow up. She misses work. She appeals. Denied. Criteria not met. She doesn't know the vendor's adherence score, tagged her as low impact for the brand. After 3 rounds and a letter from the doctor, she gets a 3-month exception. The stress spike shows up in her wearable. Her employer's wellness platform nudges sleep hygiene tips, which would be funny if it weren't her life. And the scariest one, Evan's false positive. His claim file and lab trends trigger a kidney risk model. Care management calls. Then underwriting quietly retiers his plan option for next year. Higher premium, narrower network. He doesn't connect the dots. Later, a nephrologist reviews his charts and says the algorithm overfit a blip. He files a complaint. There's no single bureau to correct, no FCRA right to an adverse action reason. He gets a case number and a promise. We're always improving. Here's where genetics sneaks in sideways. Life insurers in many states can ask about your tests or use family history. Companies don't need your raw DNA to shade you. Early mammograms, prophylactic surgeries, frequent screenings, these can serve as signals. Priya learns that the hard way. She asks if she can submit a negative clinical test to lower the quote. The reply: we consider the totality of evidence. In plain English, the pattern is already priced. On the job side, GINA blocks employers from demanding genetic info, but Kim's program never touches DNA. It just watches steps and labs. Those numbers flow to a vendor with a future cost model. HR only sees tiers and surcharges. Managers see attendance. A small slip becomes a paper trail. A year later, her raise is below target. Nobody says health. They say consistency. Cash bleeds through all of this. Marcus's rate bump. Dan's lost discount. Sophia's missed workdays. Kim's smaller raise. Priya's doubled premium. Each hit is small on paper. Together, it's a risk tax for living in a datafied body. And the creep keeps going. Auto insurers test telematics. Carriers test pharmacy-based adherence rewards. Lenders experiment with resilience metrics. The score spreads because once you can rank, you can charge. Does any of this help someone? Sometimes, yes. A care manager catches a dangerous med mix. A nudge gets steps up. A model flags rising a 1C before it's too late. But the wins ride the same rails as the pricing. If you're lucky, you get help. If you're not, you get hurdles. So how do you fight a score you can't see? You start by assuming it exists and acts like credit. Keep a log when vague risk language shows up. Ask for specific reasons in writing. Pull your prescription history. Audit your portals. Delete or decouple data you don't need synced. And if a life, disability, or long-term care quote feels off, shop states and carriers. Laws and underwriting vary. Because the moment that changes your path doesn't look like drama. It looks like an email that says due to updated risk. The legal gray. Why this is technically allowed. So how is this even legal? Short answer. The rules were built for clipboards, not clouds. Problem locked. Start with HIPAA. People think HIPAA is a force field. It isn't. HIPAA covers covered entities and their business associates. Think health plans, most providers, and vendors working for them. The second your data leaves that circle, for a consumer app, a wearable, an employer's wellness vendor, or a data broker, it can fall outside HIPAA. And HIPAA blesses de-identified data. Strip names and a few fields, say it's anonymous, and you can use or sell it. In the 1990s, that sounded fine. In the 2020s, when brokers can link datasets with address history, device IDs, and purchase trails, de-identified can be re-identified. Regulators and academics admit that. The market banks on it. Now GINA, the Genetic Information Non-Discrimination Act, passed in 2008, blocks health insurers and most employers from using genetic information. That matters. Your health plan can't hike your premium because you carry BRCA, and your boss can't demand a DNA test. But GINA has clear limits. It doesn't cover life insurance, disability insurance, or long-term care insurance. Many states leave those lines open to ask about family history or genetic tests. And once a disease is manifest, you actually have it, GINA steps back. The Affordable Care Act and disability laws pick up pieces. Studies show most people don't know these gaps. Even many clinicians miss them. So people act like they're fully covered when they aren't. What about employers? GINA bars them from asking for genetic info, but lots of wellness data isn't genetic. Steps, BMI, blood pressure, lab numbers from a screening. That's fair game if it's structured as voluntary with reasonable incentives. When the incentive is a big premium swing, voluntary starts to feel like pressure. Still legal if they follow the paperwork. Employers route the data through vendors. HRC's tiers, not genes. GINA's box stays checked. Here's another scene. Research. HIPAA and many privacy policies allow data use for research and quality improvement. Consent screens tuck broad language. Into 2 clicks. Companies spin up subsidiaries that do research and also sell insights. As long as the lawyers can argue it's de-identified and for improvement, the data moves. People think research means universities and lab coats. In practice, it can mean a commercial shop training a churn model. State laws help a bit. California's CCPA/CPRA lets you access, delete, and opt out of sale from many consumer data flows. A few states add genetic privacy rules that go beyond GINA, but it's a patchwork. Health data routed through covered entities sits under HIPAA, which can preempt weaker state rules. The same facts can be protected in one lane and exposed in another depending on which door you walk through. Portal versus app, clinic versus employer program. Companies design around the stronger rule and push traffic down the lighter path. De-identification is the workhorse loophole. HIPAA's safe harbor list was built for a smaller world. Today, location traces, family trees, and rare lab combos make unique fingerprints. Linkage is the business model. Yet if a file is labeled de-identified, it can be licensed and relinked on the buyer's side without ever handing back a name, just a persistent key. No one used PHI. They used a model feature on a key. That's how scores travel. And there's no FCRA for this space. In credit, the Fair Credit Reporting Act gives you rights: access, dispute, adverse action notices. With shadow health scoring, there's no universal right to see the profile, no standard appeal, no duty to explain a decision. Companies call it proprietary and keep it sealed. If you complain, you get a case number, not a file. The military and some federal plans have their own carve-outs. Small employers under 15 people sit outside GINA's employment title. Executive orders protect federal workers from some genetic discrimination, but that's not most people. Meanwhile, federal rules in 2013 clarified that genetic info counts as health info under HIPAA. Good for privacy inside the covered circle, irrelevant once you step out. Put it together and you see the playbook. Keep flows de-identified. Keep uses framed as research, quality, fraud, engagement. Keep high-risk scoring in lines GINA doesn't cover: life, disability, long-term care, or in vendor tools that assist decisions without becoming the decision. Keep consent broad and incentives voluntary. Keep models proprietary. And keep the pipes integrated so the same exhaust powers care and pricing. Microclimax: the loopholes aren't bugs, they're the product. Technically allowed. Deeply profitable. Hard to see. That's the legal gray the shadow health score lives in. Follow the money: private equity, insurers, and big tech. To see who profits, watch who bundles data into cash flows. Private equity starts the play with roll-ups. They buy labs for steady volume, revenue cycle firms for billing exhaust, specialty clinics for high-margin tests, then tie it together with analytics. Each asset has fees that hit like clockwork. Clinical test? Bill it. Clearinghouse hop? Bill it. De-identified real-world evidence licensed to pharma? Bill it again. In 2020, Blackstone put a flag in the genome by acquiring Ancestry.com for $4.7 billion. Media ran the back-of-the-envelope math, about $261 per profile if you treat the database like the asset. Imperfect, sure, but signals matter. It told Capital, DNA at scale has a market price. Now Insurers. They sit on the richest file cabinet, claims, eligibility, authorizations, pharmacy data through their PBMs, plus the provider networks they increasingly own. Vertical integration turns them into data turbines. Payer data informs PBM formulary tiers. PBM behavior steers prescribing. Provider groups document to the spec that boosts risk adjustment. Then the analytics arm scores populations and sells insights back to the payer line, sometimes to other payers too. The same enterprise can nudge your doctor, price your plan, and rank your risk. They label it value-based care. It is also value extraction from information asymmetry. Insurer margins look small on paper, but the magic is spread. 90 cents of every premium dollar might go to care. But who gets counted as care? Owned clinics, specialty pharmacies, and vendor subsidiaries often qualify. Data flows through those lanes and returns as allowable spend. Meanwhile, the analytics subsells risk models to employers and other carriers. Opaque scoring, recurring fees, little churn. Wall Street loves that shape. Big tech doesn't need your chart to win. They rent the ground the data lives on. Health systems sprinted to cloud in the 2020s. Storage, compute, AI toolkits. Once petabytes sit in one hyperscaler, gravity sets in. Every new dataset, every partner app, every federated model prefers to live next to the rest. Clouds bill by the SIP and the lake. Even de-identified sandboxes keep the lights on. Then come health APIs, device integrations, and model hosting. If private, equity buys the mines, big tech sells every shovel, truck, and map. Drug makers play both sides. They pay for de-identified cohorts to find trial subjects, validate endpoints, and discover targets. They also buy access to longitudinal outcomes tied to fills and labs. That data speeds approvals and extends labels, billions in upside. Consumer genomics firms pitch research partnerships. Data brokers pitch real-world evidence. Everyone pitches privacy-preserving. The common thread is rent on reuse. An asset gets sliced, licensed, and relinked without ever re-identifying in the narrow legal sense. Back to private equity's flywheel. They love long contracts with minimums, lab volumes, cloud commitments, analytics subscriptions. Layer debt on top, squeeze cost, boost cross-sell, and you've got a predictable yield. When a data stream looks bond-like, steady, sticky, indexed to population size, it slots neatly into an LBO model. If you can staple a data license to every test order, you've created a toll where none existed. Microclimax. Your body's data just became a bond coupon. There's a credit score echo here. Equifax and FICO didn't just score, they built distribution. Furnishers sent data in, lenders bought scores out, and the bureau took a cut forever. Health's version swaps bureaus for switch vendors, PBMs, and cloud marketplaces. Furnishers are providers and payers. Buyers are payers, employers, life and disability underwriters, and lenders testing resilience overlays. No one wants to call it a score, but a ranked list priced into decisions behaves like one. So how do exits work? Several ways. 1. Harvest mode. Perpetual cash from SaaS-like analytics, lab volume, and licensing. 2. IPO or spin. Float the analytics arm as a population health platform with tidy margins and sticky logos. 3. Package and sell. Roll regional labs, centralize LIS and data rights, sell to a strategic that needs footprint and evidence. For SPAC-era flavor, less hot now pitch an AI-native health data company with synthetic cohorts and federated learning. Under each, the story is the same, recurring, hard-to-switch revenue anchored by data that compounds. Insurers play defense and offense. Defense. Use scores to gate, steer, and cut leakage. Offense. Sell enablement to providers and employers, care management, wellness, engagement, while capturing more exhaust. PBMs monetize rebates and adherence programs, then license de-identified fill curves. Specialty pharmacies add nurse notes and outcomes, which become model features. Every solution prints a second check as data. Big tech's exit is simpler. Keep the tenancy. As models grow, compute grows. As compute grows, spend grows. add regulated data certifications, expand into consent orchestration, and you're not just hosting, you're shaping the governance stack. When regulators finally demand audit trails, expect cloud-native trust layers to arrive as new billable modules. And the rest of finance? Lenders and reinsurers sniff the edges. Shadow Health Score signals leak into life, disability, and long-term care where GINA doesn't apply. Reinsurers price books based on portfolio health risk. Lenders test health-adjacent variables inside financial stability models. No one wants to be first to say it out loud. They don't have to. The pipes already whisper. Midpoint reveal, you already agreed. You didn't sign a contract that said score me. You tapped allow. That's the trick. Consent isn't a moment now. It's a maze. Open your patient portal. See that banner about improving care and operations? That's one lane. Your Wearables first run setup? Another lane. Your employer's wellness app with the big green Get My Discount button? That's the fast lane. Each path bakes in broad permission. Research, quality improvement, affiliates, service providers. Sounds harmless. It's not. Those phrases are the keys that let data move and models train. Here's how it plays in real life. A hospital hires a vendor to improve scheduling. You agree to portal terms to book your visit. That vendor also runs an analytics lab under a sister LLC. To identify data flows for quality improvement. The lab builds a churn model, then sells population risk insights back to payers and employers. Your name never leaves the building, but your pattern does. Refills, gaps, diagnoses as features. On paper, nobody sold PHI. In practice, your life trained a score you'll feel later. Workplace programs push even harder. Voluntary, with a $900 swing, doesn't feel voluntary. You click through an 8-screen consent that says your employer won't see your raw data. True, but the vendor will, and the vendor can pool, de-identify, and use it for research or product development. That research hack covers a lot. One arm runs nudges. The other refines a future cost model. HR only sees tiers. Insurers see flags. You see a bill. Insurance portals layer the same pattern. Join a medication reminder app. Earn points. Connect your step counter. Get $10. Add a food log. Unlock a premium perk. Each feature asks permission. Few people read how revoking later doesn't delete past transfers. Even fewer notice that partners includes data brokers and cloud firms who aren't covered by HIPAA the way your plan is. Once your stream hits that side of the fence, it sits under consumer privacy rules. Lighter, slower, patchier. Direct-to-consumer DNA turned consent into a funnel. You mailed a tube in the late 2010s for Ancestry or traits. You probably saw a checkbox for research. Many people said yes because the pitch felt good, helped science. Later, the company signed paid research collaborations with pharma and analytics shops. They say it's de-identified. They say you can opt out. Some let you delete data and destroy samples. But here's the catch. If a de-identified slice already trained a model, your deletion won't untrain it. And if that model sits with a partner, your control ends at the company border. Dark patterns push you over the line. Consent boxes pre-checked yes. Buttons that shout continue and whisper learn more. Walls of legalese with a single scary line. Some features may stop working if you decline. So you accept, because you want your appointment, because you want that discount, because lunch break is short. Been there, done that. Trust me on this one. Designers test which words get the most clicks. They optimize your choice. Urgency unlocked. Affiliates blur the trail. The insurer owns a PBM. The PBM owns a specialty pharmacy. The pharmacy owns a tech firm. The tech firm runs Wearables. Each entity is separate. Each has its own policy, and each can pass de-identified aggregates to improve services. The net effect is one loop. Your fill history shapes adherence scores. Your device pings shape engagement. Those roll into impactability, which steers outreach and later, pricing in lines GINA doesn't cover: life, disability, long-term care. Here's the part nobody says out loud. Your discount is the business model. The wellness perk is the data capture. The research checkbox is the license. The improved services clause is the bridge from care to commerce. And because GINA walls off health insurance and employment on genetics, but leaves those other lines open, the smart money routes sensitive signals there, or hides them inside proxies. Can you say no? Sometimes, yes. California-style laws let you opt out of sale, delete, or access in consumer contexts. Some DNA firms let you nuke data and samples. You can revoke device permissions, disconnect apps, and kill auto-uploads. Do it. For real though, do it today. But know this, prior flows likely persist in models already trained, and vendors often claim legitimate interests to keep derived features. So yeah, you agreed. Not because you wanted a score, because the system made saying no feel costly. That's the midpoint twist. The shadow wasn't built behind your back. It was built with your taps. Reversals, the system bites back. Here's where the machine trips over its own logic. First, the leaks. Not just some stray email list, full medical and genomic datasets surfacing in breach notices and dump sites. Claims clearinghouses get hit. Specialty pharmacies leave a storage bucket open. A DNA side platform misconfigures access. Even if the files are de-identified, link 2 or 3 and the mask slips. Families recognize rare combos. Reporters match lab dates to Facebook posts. Trust breaks fast. Companies say no social security numbers, but you can't change your genome. That permanence turns one breach into a lifetime headache. Then the false flags. A model reads noise as risk, and people pay. An adherence score misclassifies a delivery delay as non-compliant, triggers a prior auth gauntlet, and a stable patient slides into crisis. A kidney model overfits a lab blip, and next year's plan option quietly retiers. In credit, you'd get an adverse action letter. Here, you get a script. Many factors. No path to fix the file the model believed. Clinicians push back, point to charts, but the score already propagated through eligibility, network, and price. Bias shows up in weird places. Social data stitch to claims bakes zip code history into future cost. The model says it's neutral, outcomes say it's not. Predicted spend runs hotter for patients from certain neighborhoods, so care management budgets flow elsewhere. Meanwhile, a wellness vendor's engagement index dings shift workers who can't sync at 2 p.m., then HR leans on those same tiers for surcharges. Patterns that map poverty and race become pricing signals without anyone typing those words. It's the oldest story, structure dressed as math. And the PR hits land. State attorneys general sue health apps that fed de-identified streams to ad platforms without clear consent. Federal agencies warn that de-identified isn't a blank check. Employers pause programs after workers post screenshots of penalties tied to sleep and steps. A life insurer gets dragged for asking sneaky family history questions that function like a genetic screen. None of it kills the market, but it forces a rebrand. Wellness becomes resilience. Risk score becomes member insight. Same pipes, softer labels. Data brokers get caught in the light. Journalists buy segments labeled chronic pain sufferers, opioid interest, pregnancy soon, and trace them back to app SDKs. The firms insist files are anonymous. Lawmakers hold hearings. A few states tighten rules. California's CPRA expands opt-outs. Some brokers add web forms and do not sell toggles. But the core revenue is syndication. They comply at the edges and keep the middle humming, especially through research lanes and enterprise contracts. Direct-to-consumer DNA companies face their own blowback. Users ask to delete data and destroy samples. Some firms comply and show receipts. Others bury links, slow-walk requests, or say models can't be untrained. People realize a 2010's checkbox fuels a 2020's pipeline they never imagined. Lawsuits test what broad consent really meant. Meanwhile, the private equity parent points to policies and says, "We respect choices." The market hears the caveat, choices going forward. A breach pushes regulators to ask who owns the audit trail. Clouds roll out confidential computing, clean rooms, and consent orchestration. It helps, sometimes for real, but it also hardens vendor lock-in. If your privacy fix lives inside the same platform that hosts your data, you're not leaving. That's a security win and a margin win. Big tech smiles. Hospitals breathe. Critics ask for portability and external audits. The answer is another roadmap deck. Insurers feel heat too. A major carrier's pharmacy arm gets dinged for sharing de-identified fill patterns with marketers. They promise reforms, spin up an ethics board, publish principles. Underwriting memos remind staff, don't touch genetics and health plans under GINA. Life, disability, and long-term care walls stay looser. Those underwriters retreat from direct test asks and lean harder on patterns. Early screenings, prophylactic procedures, family structure. The logic doesn't change, the paperwork does. Courts start drawing lines. A judge says an app's research carve-out didn't cover ads. Another says de-identified can still be personal data under state law if it's reasonably linkable. Companies settle, pay fines, rewrite policies. Plaintiffs' attorneys learn the playbook. So do compliance teams. The net effect isn't a ban. It's friction. Every added disclosure and audit raises the cost of doing it sloppily. Employers backtrack in public, double down in private. The nasty stuff, punitive surcharges tied to hard targets, gets toned down. The quiet stuff, risk stratification and stop-loss negotiations, vendor-member insights, keeps growing. HR vendors invent new words for the same tiers. Workers learn to game the sinks, tape trackers to metronomes, drink water before weigh-ins. Everyone pretends the program works. The spreadsheet wins. And then, the market adapts like markets do. Scoring logic moves into shell entities and advisory layers. Instead of a hard deny, you get pathway optimization. Instead of high risk, your needs supportive routing. The outputs get labeled non-determinative. Lawyers sign off. Decision makers still read the rank column first. Here's the twist that helps you. All that heat creates leverage. Breaches justify hard questions. Lawsuits open discovery. PR scares budgets into privacy upgrades. Some health systems add real consent centers. Some DNA firms make deletion and sample destruction easy. A few payers pilot audit logs you can actually read. Unions negotiate true opt-outs without penalty. It's not a tidal wave. It's a wedge. The system bites back because it's built on people. People leak. People sue. People vote with headlines. That pain doesn't stop the shadow health score, but it forces cracks where sunlight gets in. That's where pressure works. Leverage points, where people still have power. So here's the good news. You're not powerless. The pipes are big, but there are valves you can still turn. Think of this like cutting a leak in your budget. Every blocked data stream lowers your risk tax. Promise on the table. Start with your legal levers. If you live in California, use CCPA/CPRA. File 3 requests with any consumer-facing health app, wearable, or website you use. Access, delete, and do not sell/share. It's usually in their footer. Ask for a full accounting of categories shared with partners and service providers. If they claim HIPAA, fine. Then ask your provider's portal for a designated record set and an accounting of disclosures. Different roads, same goal, shrink copies. Now hit your patient portals. Log in, open privacy settings, and kill share with third-party apps you don't need. Check the connected apps list, disconnect. Anything you don't use monthly. Download your audit log if they offer one. Look for unfamiliar app names or research endpoints. If your health system uses open notes, scan for sensitive flags and request fixes where appropriate. This isn't about hiding facts. It's about stopping sloppy data trails that become score features you can't see. Wearables next. Decouple from insurers and employers. If your device is linked to a wellness program for a premium discount, weigh the real math. A $600 perk that trains a model used to tier you later might cost more over time. If you keep it, route data through the manufacturer app only. Turn off third-party integrations you don't recognize. Set upload to manual, not continuous. If the app supports deletion, schedule regular purges. Last 30 days kept, older wiped. It's like shredding old bills. Direct-to-consumer DNA is a big one. Log into your account. Open privacy and research settings. If you opted into research, opt out now. Then request data deletion, and where the company allows it, biological sample destruction. Ask for written confirmation. If you downloaded raw data, store it offline, encrypted. Don't spray it into hobby tools. And if a family member uploaded your shared tree, talk to them. Ask them to set privacy to the strictest level. Remember, family trees link identities even when samples are de-identified. Pharmacy records are their own file. Request your prescription history report from your pharmacy chain and from your insurer's PBM portal. You're looking for accuracy. Wrong prescriber, duplicates, refills you didn't pick up. Fix errors. Then check marketing preferences. Opt out of de-identified data licensing if they offer a toggle. Some chains let you turn off third-party data use in the profile settings. Do it. Treat data brokers like credit bureaus. Freeze what you can. Opt out broadly. Use state rights where available: California, Virginia, Colorado, Connecticut, Utah, plus broker opt-out portals. Prioritize brokers known for health-adjacent segments. Yes, it's tedious. Block an hour, Hit 10 in a row. Calendar a 6-month revisit. You're lowering the chance a lender or insurer buys a resilience overlay that dings you. Your medical record needs hygiene too. Request your records from your primary care and any specialist that sees you yearly. Correct obvious errors, wrong family history, outdated problem lists, conditions marked active that resolved. Ask to move sensitive, irrelevant notes to an addendum. This won't make you invisible. It will stop lazy flags from living forever. At work, push for real choices. If the wellness program is voluntary, demand a true opt-out with no punitive surcharge. Talk to HR in writing. If you're in a union, make it a bargaining point. No device mandates, no biometric penalties, vendor contracts that ban secondary data use, and human review on any tiering. Even a small shop can demand the vendor delete data after plan year close. Shopping for insurance. Read for tracking clauses. Ask agents to show you policies with no device requirements and no participation surcharges. For life, disability, and long-term care, remember GINA's gap. Shop multiple carriers and states if you can. Some states have stronger genetic privacy. Some carriers choose not to use predictive tests. Don't volunteer optional health data portals unless required. If asked about family history, answer truthfully, narrowly, and avoid speculation. Banks and lenders are testing health-adjacent overlays. You can't see them, but you can harden your credit file. Freeze Equifax, Experian, TransUnion, and Innovis. Use opt-out pre-screen to cut firm offers. Keep utilization low and payment automation on. Why here? Because when a model can't lean on shadow health signals, it leans harder on traditional credit. Make that picture spotless. Go collective. Patients groups, privacy orgs, and class actions move needles. File complaints with state AGs when apps share health events with ad platforms under research. Support bills that extend GINA to life, disability, and long-term care. Ask your hospital board for real consent dashboards, log-level visibility, not just policy PDFs. If your employer offers benefits councils, join and press for vendor contract clauses. No secondary licensing, deletion at contract end, third-party audits. Micromoves matter. Use separate emails for health apps. Disable location for anything health-related. Avoid logging social accounts into medical tools. Don't upload PDFs of lab results to random cloud drives. When a portal prompts, new data connection available, pause. Ask what flows back. This isn't about going off-grid. It's about flipping the incentives. Every opt-out raises the cost of sloppy data grabs. Every corrected chart lowers false flags. Every HR push trims punitive engagement traps. And every deletion you lock in today is one less feature in tomorrow's shadow health score. Action plan, how to reduce your risk tax. Okay, tools out. We're going to shrink the data exhaust that feeds the shadow health score. Think credit hygiene, but for your body. Simple steps, real impact. Solution time. Step 1. Inventory the leaks. Grab a notepad. List every health-touched app and device. Portals, pharmacy apps, wearables, fitness, meditation, diet, symptom trackers, fertility, sleep, insurer apps, employer wellness, DDC DNA. Write the email each uses. If any share a password, fix that now. Unique passwords plus a password manager. Add two-factor on all of it. No SMS if you can help it. Use an authenticator app. Step 2. Lock the portals. Log into each patient portal. Hit Settings, then Privacy and Connected Apps. Disconnect anything you don't use monthly. Turn off Share with third-party apps. Improve services with de-identified data. And research participation if toggles exist. Download your visit summary and audit log if available. Skim for surprise endpoints or devices you don't recognize. If OpenNotes shows errors, wrong family history, outdated meds, request corrections. Clean data won't save you, but bad data hurts you. Step 3. Wearables decoupled. Open your device app. Kill data sharing with insurers, employers, and random partners. Leave only the core device maker, and if you insist, Apple Health or Google Fit. Turn off continuous sync to third parties. Switch to manual exports for anything you truly want to share. In employer programs, weigh the math. A $600 discount that trains a future cost model could cost more later. If you keep it, route the minimum. Steps only, not sleep, not heart rate. Set calendar reminders to pause data during rough weeks so non-compliant doesn't light you up. Step 4. DNA de-risked. If you used a consumer DNA kit, log in now. Go to research/consent. Opt out of research. Then request data deletion and, where offered, biological sample destruction. Get written confirmation. Download your raw file if you truly need it, then park it offline encrypted. Do not upload it to hobby tools. Ask family members linked to your tree to set strict privacy. Remember, even de-identified cohorts can be relinked when combined with family structures. If you never tested, pause. If you must, use a clinic-based genetic counselor and ask how results are protected under HIPAA, not a consumer app. Step 5. Pharmacy Trail. Request your prescription history from your pharmacy chain and your insurer's PBM portal. Fix errors, wrong prescriber, duplicate fills, inactive meds listed as active. In your pharmacy profile, opt out of de-identified data sharing if there's a toggle. Turn off marketing communications tied to health segments. Ask how to suppress data flows to third-party analytics for product improvement. If they can't say, consider moving to a smaller pharmacy with stricter policies. Step 6. Broker blockade. Treat data brokers like credit bureaus. Freeze/opt-out where possible. Tap state rights if you're in California, CCPA/CPRA, Virginia, Colorado, Connecticut, Utah. Hit major broker portals. Yes, it's tedious. Prioritize firms known to trade health-adjacent segments. Use optoutprescreen.com to cut firm offers. Repeat every 6 months. The goal is to break easy linkages between your medical exhaust and financial overlays. Step 7. Medical record hygiene. Request your designated record set from your primary care and key specialists. Correct obvious misses, resolve old diagnoses, update family history, remove duplicative problem list items, add allergy clarifications. Ask to move sensitive, irrelevant notes to an addendum. Keep a local copy. If you switch plans, hand carry accurate summaries so new clinicians don't re-trigger costly workups that become score features. Step 8. Kill shady permissions. On your phone, open settings privacy. Turn off location for health apps. Disable Bluetooth sharing you don't need. Revoke background app refresh for anything health-related unless essential. In Apple Health/Google Fit, review every connected app. Sever anything you don't remember linking. In browsers, block third-party cookies and trackers, especially on portal logins. Step 9. Employer firewall. Ask HR, nicely in writing, for a true opt-out from wellness programs with no surcharge. Push for vendor contracts that ban secondary data use, require deletion at plan year end, and guarantee human review for any tiering. If you're in a union, make it a bargaining plank. If you can't opt out, feed minimum data and keep your own log of deadlines, syncs, and messages to contest non-compliance flags. Step 10. Shop smarter insurance. For health plans, prefer options without device mandates or participation penalties. For life, disability, and long-term care, remember GINA's gaps. Get quotes from multiple carriers. Some voluntarily avoid genetic factors. Don't volunteer extra portals or trackers. Answer family history truthfully but narrowly. If a quote spikes after holistic review, ask for written factors. Shop another state. If feasible, protections vary. Step 11. Harden your credit file. Freeze Equifax, Experian, TransUnion, and Innovis. Keep utilization low, autopay on. Why? When health-adjacent overlays are thin, lenders lean harder on classic credit. Make that picture spotless so experiments don't sting. Step 12. Go collective. File complaints with your state AG if an app shared health events with ad platforms under research. Support bills that extend GINA to life, disability, and long-term care. Ask your hospital for a real consent center, per connection toggles, visibility into data recipients, audit logs you can download. Join patient groups pressing for Fair Credit Reporting Act-style rights for health-derived scores. Micro-habits to keep, separate email for health apps, no social logins on medical tools, no PDF labs in random clouds, pause before connecting new data partners. Default to less. None of this makes you invisible. It makes you expensive to profile and harder to rank. That's the goal. Cut the risk tax now, and you buy time to push for laws that finish the job. Policy fixes. The guardrails that would actually matter. So what actually works? We need rules that hit the pipes, the score, and the money. Simple idea. Make health data act like credit data when it's used to judge you, and close the holes that let genetics leak into pricing. First, close HIPAA's gaps. Today, HIPAA shields your data inside covered entities. then loses grip the second it hits a consumer app, a broker, or a research vendor. We need a clear federal floor that follows the data, not the logo. If a company collects, processes, or sells identifiable or de-identified health signals, including claims, labs, wearables, pharmacy, or genetic info, it should be covered by health-grade privacy duties. That means purpose limits, no silent secondary uses, real deletion rights, and penalties that sting. And de-identified can't be a magic word. Treat linkable data as protected. Second, fix GINA's blind spots. The Genetic Information Non-Discrimination Act stops health insurers and most employers from using genetic info. Good, but it leaves life, disability, and long-term care open. That's the back door. Extend GINA's core ban to those lines. Make it illegal to request, require, or use genetic tests, family history, or genetic inferences for underwriting. Some states do a piece of this. We need it nationwide, with preemption that sets a real floor and lets states go stronger. Third, bring FCRA-style rights to health-derived scoring. If a profile or model helps decide your premium, network, job fit, loan price, or housing, anything material, you deserve the basics. Notice, access, specific reasons, and a timed dispute process that forces a fresh look. The Fair Credit Reporting Act did this for money. Do the same for health-adjacent decisions. Define health decisioning systems, register vendors, require furnisher accuracy, log accesses, and audit regularly. If a company can't explain a decision in plain English, it shouldn't be allowed to use that model. Fourth, ban health scoring in employment and lending. Draw a bright line. Employers can't use health-derived scores, risk tiers, or wellness compliance for hiring, pay, or promotion period. Lenders and landlords can't use medical, genetic, or health proxy data in pricing or eligibility. The ADA and ESOA aren't built for this gray zone. We need explicit prohibitions so resilience metrics don't become a backdoor tax on illness. Fifth, require data fiduciary duty. If you hold health data, you owe the person a duty of loyalty and care. No using their information in ways that clearly harm their interests, like selling risk flags to underwriters that will price them up. Make executives attest to this yearly. Tie it to penalties and a private right of action, so people can actually sue when firms cross the line. Sixth, mandate model transparency, safety, and auditability. Not the secret sauce, just the ingredients and guardrails. If a model touches care, coverage, or pricing, file a public model card. Purpose, inputs, known limits, bias tests, monitoring plans, human-in-the-loop points. Require independent audits, not a vendor grading itself. Build event logs so affected people can see when a score touched a decision. And when models drift or fail, force sunset or retraining with fresh consent. Seventh, default to data minimization and time-limited consent. Flip the toggle. No broad, forever consent buried in a portal. Make choices granular, off by default, and easy to see and change. Put clocks on data. If you collected for care, don't keep forever for improvement. Archive or delete after a fixed window unless a patient renews permission. For research, use specific projects, clear benefits, and opt-in only. Eighth, strengthen breach and re-identification penalties. If a firm re-identifies a de-identified file, that's a violation with big fines and bans. If a breach exposes genomic or medical, linkage keys require immediate notices, lifetime monitoring, and free deletion support where feasible, including sample destruction at DNA firms. Ninth, portability and switching. Let people move their health data, full designated record sets, pharmacy histories, device logs, between providers and apps without dark patterns. Standard formats, clear endpoints, no ransom fees. Portability breaks lock-in and weakens data moats. 10th, procurement power. Tie Medicare, Medicaid, and federal contracts to these standards. No secondary licensing, strong consent, audit logs, and independent model audits. Big public buyers can move markets fast. Finally, fund enforcement. Rights without cops or vibes. Resource the FTC, HHS-OCR, and state AGs. Create a health data ombuds office to take complaints and force fixes across agencies. Publish a yearly health scoring report so we can see the system we're living in. Do this, and the shadow health score stops being a black box that taxes your life and starts being a tool you control, or a tool that simply can't be used against you. Microclimax. Guardrails turn the score from weapon to wrench. Macro lens. Why your body became an asset class. Step back and follow the cash. In the 2010s, yields fell and safe income got scarce. Pension funds, insurers, and endowments hunted for durable cash flows that don't swing with markets. In the 2020s, private equity pitched a new vein: biology. Not pills, not clinics, data. Lab results claims wearables and yes, DNA. Why? Because human bodies generate steady signals for decades. Predictable, billable, refinanceable. Diagnostics turned into a metronome. People age. Chronic disease rises. Diabetes, heart disease, cancer screenings. These aren't fads. They're long-duration rhythms. Each test hits revenue today and throws off data you can resell tomorrow as real-world evidence. Link that to outcomes and you've got proof that makes pharma pay more. Tie it to risk and you've got a pricing edge. Wall Street hears two words: recurring revenue. Urgency. This cash flow doesn't slow down, it compounds. AI and cloud made the math sing. 10 years ago, sifting petabytes was too pricey. Now storage is cheap, compute is elastic, and model kits are point and click. That drops the cost to extract rent from data. A claims feed plus pharmacy, Phil's used to be reporting. Add lab trends, device pings, and social signals, and it becomes a score factory. Even when companies won't say score, they rank, bucket, and route like one. Same behavior, prettier name. Insurance loves granularity. The older play was pooling. Same premium for broad groups. The new play is sort. If you can predict a person's future cost probability, you can nudge them to certain plans, restrict some drugs, and design engagement that screens for friction tolerance. And in lines GINA doesn't touch: life, disability, long-term care. You can underwrite more aggressively, sometimes with family history or screens as stand-ins. Fine-grained risk raises margins quietly. This is where DNA slides in. In 2002, Blackstone bought Ancestry.com for $4.7 billion. Headlines did napkin math. About $261 per profile if you treat the trove like the asset. Is that the true price of a genome? No. But markets don't need perfect. They need signals. That signal said, at scale, personal biology is valuable and tradable. Paired with longitudinal medical exhaust, its yield gets clearer. Licensed today for research. Leverage tomorrow for targeting. Roll those rights into a portfolio, and you've got a cash flow story investors understand. Moats matter. Data has gravity. Once a health system parks terabytes in one cloud, partners land there too. APIs get built, models get tuned, and switching gets painful. That stickiness, plus exclusive data sharing deals, looks like a fortress. The more a firm integrates payer, PBM, provider, and analytics, the tighter the loop. Each arm feeds another. Each transaction throws off billable exhaust. It's platform economics wearing a lab coat. There's also a timing edge. Demographics are destiny. The 2020s bring more seniors, more meds, more tests. Chronic conditions produce regular touchpoints. That regularity is a bond-like stream, perfect for leveraged buyouts. Lock in multi-year contracts, labs, analytics, SaaS, cloud commitments, and you can underwrite debt with confidence. Squeeze cost, upsell data licenses, and the free cash flow line gets smoother. That's private equity's comfort zone. Meanwhile, the credit score playbook offered a template. Equifax and FICO proved you can turn human risk into an industry. Furnisher networks, proprietary models, subscription pricing, and no easy appeal. Health's version swaps late payments for gaps in care and adherence, then sells outputs to decision makers who can't or won't build in-house. The black box becomes infrastructure. Once embedded, it's hard to rip out. The last piece is narrative. Investors want inevitability. Biology provides it. Bodies age on schedule. Algorithms improve as data piles up. Regulators move slow. And every privacy fix, clean rooms, consent hubs, conveniently lives inside the same platforms that already rent you storage. Even backlash can entrench winners. Breaches justify new paid trust layers. Audits become features. Compliance turns into margin. Microclimax. Even the fixes pay the landlords. So your body became an asset class because it ticks every investor box. Large market, long duration, high recurrence, defensible moats, rising data density, falling compute costs, and proven score economics. Add a headline deal, $4.7 billion for the biggest consumer DNA trove. And you've got a price tag Wall Street can paste on a slide. Why does this matter to you? Because once your biology is modeled as cash flow, the system optimizes for yield. Helpful care and harsh pricing run on the same rails. If the rent from your data grows when you're more engaged, you'll be nudged. If margins rise when risk gets sorted sharper, you'll be sorted. And unless guardrails catch up, the shadow health score will be the quiet meter that decides how much life costs you. What changes if we do nothing versus act? So what happens if we just shrug? The shadow health score hardens. Like Equifax in the 1990s, it becomes how it's done. Employers bake tiers into budgets. Insurers tune networks and prior auth by rank. Life, disability, and long-term care underwriters lean on family history and holistic proxies GINA doesn't touch. Lenders test resilience overlays. You feel it as a quiet surcharge on everything. Premiums, interest, opportunities. A health caste system, priced in. The loop gets mean. Data says you're costly, so you hit hurdles. Hurdles delay care. Delays worsen outcomes. Worse outcomes justify the score. That spiral is fast because biology doesn't wait. And there's no FCRA here. No right to see the label, no straight appeal, no clock that forces a fix. You get scripts like many factors, while the model keeps learning the wrong lesson from your life. Ignore it long enough and the pipes lock. Private equity cements multi-year data rights into lab and analytics deals. Clouds deepen moats with trust layers that are real and also sticky. Vendors rename scoring as member insights. The market moves on. By the late 2020s, this looks normal. By the 2030s, kids grow up thinking risk tiers at work and in loans are just adult life. Now flip it. What if we act? Start small and personal, then scale. You treat your health data like money, because it is. You opt out of research you don't trust. You delete stale device feeds. You request sample destruction from DNA firms that allow it. You clean errors in your chart and in your pharmacy history. You cut off brokers that stitch your life into segments like likely chronic. It won't make you invisible, but it will raise the cost to profile you and blunt bad labels. At work, you and your team push for true opt-outs with no penalty, human review on any tiering, deletion at plan year end, and a ban on secondary licensing. In your plan shopping, you avoid device mandates and participation penalties. For life, disability, and long-term care, you shop carriers and states because underwriting and laws differ. You treat vague, holistic pricing as a signal to keep moving. Collectively, you go louder. You back bills that extend GINA to those uncovered lines. You demand FCRA-style rights for health-derived decisions. Notice, specific reasons, access, and a time dispute that actually pauses the hit. You push HIPAA Plus rules that follow the data, whether it's in a portal, a wearable, or a research LLC. You press for model cards and independent audits when scores touch care or price. And here's the shift that matters most. From invisible subject to active owner. Hospitals roll out consent centers with real toggles because boards feel heat. Vendors move deletion up front because sales get stuck without it. Clouds ship audit logs normal people can read because contracts require it. The system won't turn altruistic overnight, but incentives bend. Data rents fall when people say no at scale, and when law makes silent scoring expensive. DNA's $261 signal cuts both ways. It told Wall Street your biology is an asset. It tells you the same, so you price it first. Treat every permission like a payment. If value doesn't flow back to you, in care, in cash, or in rights, don't sell. That's how we stop paying a risk tax for just being human. Action. Lock your data. Push your HR and insurer. Back the guardrails. The market already priced your future. The only question is whether you price it first. Lock down your streams today. Push your employer and insurer for real opt-outs and audits. And back laws that close GINA's gaps and add FCRA-style rights. Subscribe for deep dives that help you take control, cut your risk tax, and build a moat around your data. Let's be honest, nobody's coming. We build it. Let's get hustling.